24-year-old man with decay, presented with decay. pH is 7.18, bicarb is 10, PCO2 is 38. Most appropriate interpretation. So pH is 7.18. If the pH is less than 7.35, it is acidosis, and this acidosis could be respiratory or metabolic or maybe mixed. So bicarb is 10, so it is metabolic acidosis. Metabolic acidosis. In metabolic acidosis, to see the compensation, appropriate compensation हो रहा है कि नहीं हो रहा है, इसके लिए we will use winter formula. Winter formula we will use for metabolic acidosis to see the appropriate respiratory composition. So winter formula is 1 to see the expected PCO2. Expected PCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. So expected PCO2 is equal to 1.5, bicarb is 10 plus 8 plus minus 2. ये आ जाएगा 23 plus minus 2. Okay, so expected PCO2 here is 23 plus minus 2. Okay, but the actual PCO2 in the question is 38. It is more than expected PCO2. It means it is contributing in the respiratory acidosis. If actual PCO2 is less than expected PCO2, then it will contribute in respiratory alkalosis, and if it is equal to expected PCO2, then appropriate compensation. So but here is actual PCO2 is 30 is more than expected PCO2. Okay, so respiratory acidosis is also contributing. So respiratory acidosis. So here is mixed metabolic acidosis and respiratory acidosis. So option B is correct. Okay. Option A is wrong. It is not pure metabolic acidosis with adequate, not adequate compensation. Okay. So let's move to the next question. Question number 2 is 60-year-old man, diabetic patient presented with ST elevation in the lead 2-3 AVF. So what is your interpretation if there is ST elevation in the lead 2-3 AVF? It is inferior wall MI. On examination, BP was 80/50, JBP elevated, lung is clear, which drug should be avoided? So in inferior wall MI presented with hypotension. Let's see. Option is aspirin. Definitely we will give aspirin. Clopidogrel, yes, we will give as antiplatelet. Nitroglycerin is a vasodilator and it will reduce the preload, so it will worsen the hypotension, so we will not give nitroglycerin. One more thing, inferior wall MI is only MI where we can give the IV fluid and hypotension will respond to IV fluid. Primary PCI, definitely we will do primary PCI if patient is within window period. Okay, so nitroglycerin we will avoid just because it will worsen the hypotension. Let's move to the next question. A CKD patient present with potassium is 7.2, ECG peaked T wave, QRS widening. Which treatment should be given first? CKD patient is complication is electrolyte imbalance, there is hyperkalemia, and hyperkalemia is a acute emergency. Always treat hyperkalemia. ECG changes in hyperkalemia is very important for your exam. So first of all, there is a peaked or tall T wave. This is P. This is P wave. Q R S T. Okay. But in hyperkalemia, P wave get flattened and QRS widened and T tall. Okay, tall T wave, widened QRS and flattened P wave. And if the hyperkalemia persistent, then sine wave pattern in severe hyperkalemia, and finally asystole if not treated early. So hyperkalemia always treat early. Okay, because if you will not treat, then cardiac arrest will occur. Okay, so main important thing is to stabilize the cardiac membrane by giving calcium gluconate. So first thing you will give calcium gluconate, so option C is correct. And after calcium gluconate you will give insulin and dextrose drip, that is GI drip. In case of refractory hyperkalemia you will do hemodialysis. Okay, so here option C is correct. Next question, patient with septic shock. Septic shock is also very important topic. He has given 30 ml per kg fluid crystalloid, but mean arterial pressure remain 58. Okay, despite adequate fluid. First vasopressor. If any patient presenting to you and you diagnosed as a case of septic shock and you started fluid resuscitation 30 ml per kg, but still the patient is not responding to the fluid, next step is to give vasopressor. And which vasopressor is you will choose? First vasopressor is norepinephrine, so option C is correct. Norepinephrine is a first vasopressor. After norepinephrine you will use vasopressin. Okay, so option C is correct here. Moving to the next question, number 5. A patient with acute pancreatitis. Pancreatitis is also very important topic. Develop fever on date. कभी भी किसी पेशेंट को फीवर कब आएगा? जब कोई बॉडी में इन्फेक्शन होगा. ओके, CCT, so pancreatic necrosis. Necrosis is acting as source. ओके, फीवर का कोई पेशेंट आता है तो ऑलवेज रूल आउट द कॉज, उसका सोर्स कहाँ है वो आइडेंटिफाई करना होता है. बेस्ट मैनेजमेंट, फीवर को ट्रीट करने के लिए अगर कोई इन्फेक्टिव है तो व्हाट यू विल गिव? एंटीबायोटिक्स प्लस रिमूवल ऑफ द सोर्स. मान लो कहीं पे पस है तो क्या करोगे? उसको एंटीबायोटिक के साथ साथ क्या देते हैं? इंसिजन एंड ड्रेनेज. एंड इन दिस केस नेक्रोसिस इज एक्टिंग एज सोर्स. ओके, सो वी विल गिव एंटीबायोटिक प्लस मिनिमली इन्वेजिव नेक्रोसेक्टमी. नेक्रोसिस को हटाओगे प्लस एंटीबायोटिक दोगे. ओके, सो ऑप्शन सी इज करेक्ट. मूविंग टू द नेक्स्ट. A woman developed severe postpartum hemorrhage. PPH is also very important. Bleeding persistent despite of oxytocin and uterine massage. Next best step. Postpartum hemorrhage is also very important. Here bleeding is persistent despite of giving oxytocin and uterine massage. So next step what you will do? Next step, uterine balloon tamponade. So option C is correct here. Okay, uterine balloon tamponade. Moving to the next question. 5-year-old boy has edema, BP is 150/90, cola colored urine and RBC cast and low complement level. Most likely diagnosis. So any patient presenting to you with edema, always you should rule out possible etiology. Edema can be due to cardiac cause, it could be due to hepatic cause, it could be due to renal cause. Okay, and also due to protein deficiency, protein losing enteropathy, or protein losing in the urine that lead to the nephrotic syndrome and hypoalbuminemia. Okay, so if in urine RBC cast is present, it means the origin is glomerular origin. So this patient is a case of glomerulonephritis. So here PSGN, post streptococcal glomerulonephritis is diagnosis. Okay, MCD, minimal change is also a very important. Okay, so always cover all these questions. Okay, next is patient develop fever, rigidity, autonomic instability. CK is 15,000 after haloperidol, drug of choice. First of all, you should make the diagnosis. After giving haloperidol, patient develop rigidity, autonomic instability and fever, and creatine kinase is 15,000. Okay, so it is a case of neuroleptic malignant syndrome. Drug of choice in neuroleptic malignant syndrome is dendroline, but here dendroline not given in the option. So other drugs, bromocriptine. Okay, so option B is correct. Bromocriptine you can give in the neuroleptic malignant syndrome. Into the next question. patient present with stroke after 19 minutes of onset of NCCT, brain shows no hemorrhage. BP is 175 by 95. Next best step. If any patient presenting with a stroke, then first thing you will do NCCT head just to rule out the hemorrhage. Okay, because if patient is presented in the window period, so you can thrombolize the patient if there is no hemorrhage. Okay, and window period is for a stroke is 4.5 hours. So patient presented to you within 90 minutes. So best next step what you will do? Thrombolysis. So option B is correct. IV thrombolysis. Very important. Okay. Moving to the next question. Here a question: patient with chronic hyponatremia. Hyponatremia is also very important topic. Sodium is 108 is corrected to 122 within 8 hours. Most feared complication. कभी भी कोई पेशेंट अगर हाइपोनेट्रीमिया का आता है तो बहुत ही रैपिडली सोडियम को करेक्ट नहीं करना होता है. इट शुड बी विद इन 24 आवर्स 8 मिलीक्वलेंट पर लीटर करेक्ट कर सकते हो, उससे ज़्यादा नहीं, नॉट मोर देन 8 मिलीक्वलेंट पर लीटर, अदरवाइज द पेशेंट विल डेवलप CPM. ओके, सो हियर ऑस्मोटिक डीमाइलिनेशन syndrome, it is very dangerous complication. So always correct sodium gracefully. Okay, so I have completed 10 question, and I will post daily 10 MCQ. So I will cover these important topics also, and if you like this video, please subscribe my channel. Thank you so much for watching this video.